This question is asking which characterizes the low CD4 T lymphocyte count in individuals with AIDS, less than 50, less than 100, less than 150, or less than 200 cells per cubic millimeter. Now, although I would argue that memorizing a lot of numbers is not really important for your boards, this number is one that you should absolutely have memorized because it is so important to know. Before we talk about what the exact threshold is for the transition from HIV to AIDS, let's just talk about HIV and AIDS as a whole. The human immunodeficiency virus is a virus that targets the immune system, specifically those CD4 T cells. This infection can be found in most bodily fluids and is usually spread via sexual contact or injection drug use. Signs and symptoms of HIV depend on the stage of infection. Initial symptoms include fever, headache, and sore throat, while later symptoms include swollen lymph nodes, weight loss, and diarrhea. Profound immunosuppression in patients with this condition can result in opportunistic infections, neoplasms, and other systemic effects. Head and neck manifestations are also very common in HIV and may even be the first sign of an HIV infection, which is why it's really important for us to know about this condition as a dentist. There is actually no cure for this infection, but antiretroviral drugs are used to stop the virus from replicating in the body, so these drugs kind of stop the progression of the condition. If untreated, HIV will progress to AIDS, or acquired immunodeficiency syndrome, and this occurs when those CD4 T cells drop below a certain level. Now, AIDS is the most advanced stage of an HIV infection, and it's characterized by a number of those opportunistic infections. These infections could be something that the body typically easily fights off, but because the immune system is so compromised, these infections can be fatal to patients. But back to the question. For reference, a healthy CD4 T cell lymphocyte count in a patient without HIV or AIDS would be between 500 to about 1,500. A low CD4 cell count would be below 500, and that means that HIV has weakened the immune system. Now, when the patient has officially progressed to AIDS, it is when the cell count drops below D, 200 cells per cubic millimeter. Now, since all of these answer choices are lower than the 200 cells, they all obviously do represent someone who currently has AIDS, but 200 is the number used as the official benchmark for the transition from HIV to AIDS, so that would be the correct answer. So like I said, less than 150 is someone who has AIDS, but that is not the benchmark that we use. Less than 100, the patient definitely has AIDS, but once again, not the benchmark. And once again, 150, they definitely have AIDS, but it's not the benchmark that we use to transition from HIV to AIDS. So it's very important to remember that someone with HIV will officially progress to AIDS when their CD4 T cell lymphocyte count drops below 200 cells per cubic millimeter. We have an 88-year-old male who's here for an exam. He has hypertension, type 2 diabetes, he's taking some medications, and we notice multiple brown and circular nodules on the forehead and cheek, and the patient reports he's had them for a long time, and we can see in this image how clearly they are presenting. And we're asked what is the most likely diagnosis of these dermatologic findings. Now, we honestly should be able to determine the diagnosis for these lesions solely by looking at the images, but some information given to us in the patient box can help us narrow down the diagnosis if we are unable to just diagnose from the picture. This description of the lesions as multiple brown circular nodules, as well as their location on the forehead and cheek, is really helpful information. This very accurately describes the correct diagnosis, and it's very commonly seen in these locations. A final other indicator that I want to point out is that this patient reports that he's had these lesions for a long time. These are not lesions that have recently formed or recently changed in size or appearance, according to our patient. Now, based on the presentation of these lesions, their description, their location, and the fact that they've been present and constant for a long time, these lesions are definitely an example of B. seborrheic keratosis. Now, this is a very common benign cutaneous lesion of epidermal origin. They're seen on sun-exposed surfaces with sebaceous glands and are most common on the face, trunk, or extremities. These lesions are mostly seen in those over 40 years of age, which our patient definitely is, and they're sharply demarcated, slightly raised plaques or nodules. They range in color from tan to brown to nearly black, but they have a homogeneous color. Clinically, they have a characteristic stuck-on appearance that is often compared to dirty candle wax stripped onto the skin, or mud thrown against a brick wall. Pretty descriptive terms here. There typically are several of these lesions present rather than just one, and more tend to appear as a person ages. A variation of these is dermatosis papulosa nigra, which is just a collection of small seborrheic keratoses that are found in 35% of African Americans. These do not require any treatment. Now, although this is definitely the correct diagnosis for these lesions, let's go through the other answer choices, talk about what they are, and how they're similar and different from seborrheic keratosis. We'll start with a keratoacanthoma. Now, this is a benign skin tumor that typically occurs on sun-exposed areas of the body, especially the head, neck, and extremities. They often begin in a hair follicle, with the kerato referring to keratin that makes up hair, and they're most common in older men, kind of like our patient. These lesions are typically caused by sun exposure, but can be due to other causes, such as human papillomavirus or an injury to the skin. Clinically, they are raised, dome-shaped, and rapidly growing with a central keratin plug. They are solitary lesions that are sharply demarcated, erythematous, or skin-colored, with a similar appearance to squamous cell carcinoma. They can be locally destructive and can cause scarring, so surgical excision is the recommended treatment. Now, how is this different, and how is this similar to our seborrheic keratosis? These lesions are found in the same sun-exposed areas and are both most commonly seen in older patients. Both lesions are also benign, raised cutaneous lesions, but that's really the extent of the similarities. But how are they different? This has no association with sebaceous glands, but is instead associated with the central keratin plug. This is a rapidly growing lesion and not a slow-growing lesion that would have been present for a long time. This lesion is typically erythematous or skin-colored instead of tan, brown, or black. The etiology of this lesion is specifically linked to sun exposure, human papillomavirus, and injuries to the skin. These are also solitary lesions instead of the multiples that we saw and our seborrheic keratosis. A final difference is that these are locally destructive and are typically treated, while seborrheic keratosis is asymptomatic and does not require treatment. Next, we have a xanthoma. Now, a xanthoma is just a deposition of cholesterol-rich material, meaning that they're the result of lipid accumulation within the skin. These are believed to result from irritation or an unknown immune reaction, but their etiology is still not completely understood. These are uncommon, benign, papillary, or exophytic growths typically found on the gingiva, hard palate, and alveolar ridge. They can also present cutaneously throughout the body and are often found in this area right above the eye. They're usually solitary, sessile, or pedunculated lesions with a verrucous or cauliflower-like surface. They're usually slow-growing, asymptomatic, and range from around 2 millimeters to 1.5 centimeters in size. They can range in color, but are typically yellowish, white, to pink due to the amount of cholesterol present in the lesion. They're treated via wide excision and do not typically recur or convert into a malignancy. Now, is this similar and how is this different to our correct diagnosis? These are both raised benign growths that are slow-growing and asymptomatic. But how are they different? Now, xanthoma is a deposition of cholesterol material and has no association with sebaceous glands. These can be seen intraorally or on the skin, while seborrheic keratosis is only found on the skin. These are typically solitary lesions, they're not found in multiples, and are more of a yellowish, pinkish white than a tan, brown, or black, and these are also typically treated. And finally, we have melanoma. And I know you've heard of melanoma, but let's still talk about it in depth. This is a malignancy of melanocytic differentiation and is the third most common skin cancer. The risk factors for melanoma include being fair-skinned, a family history of melanoma, a tendency to sunburn or freckle easily, or a history of blistering sunburn early in life, as well as being immunocompromised. This is most often seen in patients 40 to 70 years of age and is more common in older males. This can be seen cutaneously and mucosally, and high-risk sites are the back, arms, neck, and scalp. The common clinical signs for melanoma are known as the ABCDEs: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolving in size or color. So that's the ABCDEs. There are different types of melanoma depending on their location and their growth pattern. Are known as the ABCDEs: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters,